Morning, everybody. So this is a combined committee meeting of CDPST and QIPP. And we will pass the baton as we need to. We have two sets of minutes to approve, but we don't have a form for QIPP yet, so we're going to just work on the CDPST minutes from February 1st. And I actually have two corrections. One is where it says document 1 for February 1. And then on page 4, third paragraph down, it says clerk was the winner, it should say prerequisite. So with those corrections, are there any other corrections?
Getting to the correct one there.
Okay.
Yes.
Okay.
Thank you. Motion to so was that.
Okay. All in favor? So. Okay, so those minutes are approved with corrections. As I said, we'll defer approval on the QIPP minutes until we get a member of the committee here. So, moving ahead, we are going to start by reviewing how the prime program is, the PCMH prime program is going. It's the 1-year mark, so congratulations on that. And we will, after that, move on to ACO certification, especially description of technical assistance design, and then move on from there. So I'll turn it over to Catherine Harrison.
Great, thanks, Dr. Allen. So we have some slides prepared today for a discussion about the PCMH Prime certification program about a year into the program. So as you know, we regularly report to the committee about the progress of PCMH Prime, but we often look at it mostly by a sense of the number of practices that are participating in the program. And while that's certainly an obviously important way to gauge what's happening in the program, but as we entered the second year of PCMH Prime, we wanted to gain a more robust picture, really, of the participation in the program to date, and look at it by some of the characteristics of practices that are participating in the program, in addition to some information about how they're participating or what their experience has been to date. So we've undertaken some analysis of the program, and my colleague Kelsey Bregman is going to take us through that in just a moment. The analysis uses a variety of data sources, but chiefly participation data that we collect directly in the course of our management of the program, and data from NCQA, both on their set of recognized primary care medical homes in Massachusetts, and also on the performance of practices against the PCMH Prime criteria for those that have already submitted to NCQA. So we do call this our kind of 1-year look back, but the data are actually current as of today. So it's actually more like the first 15 months of program experience. Now the work, this analysis I think is plenty interesting on its own, but we also, what we want to do at the end of the discussion today is really use this information to think about the second year of the program. So we want to set some priority areas of focus for our work in year 2, and we want to share our thinking with you on what those areas might be, but also hear from you and have some discussion about where we are and where we want to be with PCMH Prime as we go forward. So with that, I will hand the baton to Kelsey.
So to begin with, one data point that we've been very interested in is the overall participation rate in PCMH Prime. So what we found is that 33% of Massachusetts clinicians in NCQA PCMHs are participating in PCMH Prime. And by that I mean practicing in either PCMH Prime certified sites or in sites on the pathway to Prime. And to give a little bit of context for how we calculated this statistic, for the denominator we used Massachusetts clinicians in NCQA PCMHs because that is a prerequisite for our program, and it is those practices with PCMH capabilities, baseline capabilities that we're really targeting initially for participation. Here's our classic number slide. So just as a quick update, we currently have 92 practices currently participating in Prime. 35 of those are PCNH Prime certified. 56 are on the pathway to Prime. And there's one practice that's working towards NCQA PCNH recognition and PCNH Prime certification currently.
In our slide, you have 3 practices that we're on. Could you just speak a bit about the reasons?
Yep, certainly can. So 2 of those practices withdrew because they changed system affiliation, kind of in the middle. And then there was one practice that had some competing priorities, such as EHR implementation, and also cited a lack of financial incentives for withdrawal. So this next slide is really just for your reference as we go through the next few slides. It just lists all at a high level our participating practices by program category. So the next 3 slides I'm going through are going to give an overview of the characteristics of practices that are participating in Prime. So one of the things we look at is the level of NCQA recognition of participating practices. And what we found is the majority of certified practices are 2014 level 3 PCNHs, and the majority of practices on the pathway are 2011 level 3 PCNHs. I think this speaks to the fact that a lot of practices hear about PCNH Prime and end up applying for Prime as they kind of upgrade from 2011 to 2014 NCQA recognition. We also wanted to explore the percent of practices that are participating in alternative payment models. So to that end, we found that 78% of practices on the pathway or that are certified are part of provider organizations that are in risk-based contracts. And to qualify this statistic a bit, I will say this is an approximation. We don't have perfect data on this. We use our RPO data to kind of map practices to risk-based contracts, but that data isn't granular enough to know for sure which individual practices are participating in risk-based contracts. We only really know that at a higher entity level. So we think this is a good approximation, but it's probably a slight overestimate of the APM organization. Another thing that we looked at and found is that a lot of the practices participating in our program are community health centers. So specifically, 39% of participating practices are FQHCs. And then lastly, we looked at the size of practices participating in Prime as measured by number of clinicians in the practice. And as one of the goals of our program is for it to be relevant and achievable to practices with different levels of resources, we were really happy to find that we had a big range in size, practices as small as only 1 clinician to practices with as high as 7 clinicians. We also want to look at the degree of administrative support that program participants receive. So to that end, on this slide, we categorize practices by number of sites, as well as FQHC status, in order to kind of approximate the level of centralized support they might have for practice design. And overall, what we found is that the majority of our practices are part of multi-site provider organizations that have some degree of administrative support. And again, I'll say for this, administrative support is the sort of thing it's very hard to measure. So, we certainly recognize that these categorizations are somewhat artificial, but we think, broadly speaking, this kind of gives a good sense of the type of support our practices might have in order to achieve that. So, in terms of geography, certified and pathway practices are located across the state. Though, as you can see, there is a good degree of concentration in the Boston area, especially for certified practices. And as we continue to expand the program, we do hope to continue to engage practices, across the state in different regions.
Before you move to the payer engagement, I'm just wondering if we've talked to practices that have not chosen to participate yet, and so finding out why. And I'm particularly interested in the FQHCs because a lot of them are sort of adhered to the patient centered clinical model. And I don't know, is that because they're already in CQA and they're just waiting for their next sort of cycle, or is there a reason why they chose not to pursue?
Yeah, that's something we haven't looked in all that much to date, but certainly can think about going forward. Yeah, as I said before, I do know that a lot of them really need to apply as they're making that conversion, so I would expect.
Right, you're asking about practices that are doing NCQA but not choosing to do practice, not ones that aren't doing it.
Oh,
Yeah, we've had a few conversations, not a systematic, try to survey the landscape. We certainly have heard from some that, similar to the one practice that withdrew, that there may be some competing priorities. I think for some primary care sites that have been involved in, the process of participation in ACOs, and particularly in the Mass Health ACO program coming up. On the one hand, it might be a perfect time to think about PCMH prime. On the other hand, there may be some competing priorities and resource demands, particularly to the extent that there's some, hopefully it's not too high, but some administrative burden associated with collecting the information necessary to apply. So we've heard that a little bit, but I as Kelsey said, I think it's a good suggestion, something that we might want to do to round out our picture of some of the drivers of that decision.
So to shift away from some of the practice demographic information, this slide goes over our peer engagement efforts over the past year. So we've worked with payers such as Harvard Pilgrim, the JIC, and Mass Health to start conversations around how to support our HPC's certification programs. So Harvard Pilgrim, I would say, is a payer we've engaged most specifically about the PCMH Prime program. So as a few examples of what we talked to them about, they made 2016 behavioral health quality grant dollars available to support grantees seeking PCMH Prime. And they've also indicated a willingness to partner in other ways, such as marking prime status of practices in their provider directories. We've also talked to the GIC and have continued to have conversations with them about how to link their quality improvement programs with HPC certifications. And then Mass Health, broadly supports PCMH and behavioral health integration efforts through their ACO model, and through their ACO RFR process.
The other payers,
Yeah, the other payers are still, I think our strategy for payer engagement is something we can talk more about. There's a lot of activity, obviously, in the marketplace around supporting patients that are in primary care, particularly in light of the ACO model. My sense is that most organizations are focused on that, sort of the accountable care model, more than they are on pure medical home these days. But it's one of the things that we do have on our priority list for the coming year, and would be interested in strategizing with you all about the best ways that we can engage payers at this stage.
So I have a more philosophical question. And that is, do we know from practices that have engaged in this whether they feel that this whole process, both the prime part and the NCQA part, are actually moving them towards practice transformation? This isn't our goal, and actually helping them to better integrate the behavioral health. What do we know from the practices that we do that way?
I don't think we know all that much right now, but that is one of the main things we're hoping to get out of our technical assistance program. As part of that program, we're doing a TA evaluation And we will be asking survey questions such as, how much did TA help you, achieve new PCMH prime criteria. So we're hoping to get a little more flavor.
Yeah, but I mean, it's one thing to do the criteria, which is part of the transformation, but did it make your practice actually work differently? Or did you feel that you were delivering care in a better way, reaching more patients or solving more behavioral health issues? I mean, isn't that the real goal? And so do we understand whether we're accomplishing it or not?
I think at this point, we don't have a lot of clarity on that. The program in this first year, I think, is likely to have targeted and brought in practices that perhaps had been working on behavioral health integration for some time, perhaps had been NCQA recognized for a while, and are taking this additional step of getting Prime certified as a recognition. I do think that through the TA program we will get some more one-on-one engagement with practices that helps us understand, maybe in addition to some of the reasons that they chose to participate in the program, what are the things about it or what are the things around behavioral health integration that they're working on, and how do those translate into the kinds of changes at the practice level that we're most interested in. I would say that we have a strong commitment through PCMH Prime not only to recognize practices for their work, but to really help practices with behavioral health integration. It's less about whether or not someone is going to get our stamp of approval and more about improving their practice. So we certainly will be emphasizing that as we go forward.
And learning from them as well, because when somebody has done something creative or innovative that brings them forward, there might be 10 other practices that could do the same thing if they heard about it.
Absolutely.
So I think these next couple slides are some of the most exciting in my presentation because they really start to look at how practices are currently performing on our standards. So this graph here shows the percent of practices that have submitted a PCMH Prime survey that are meeting each of our criteria. So as you can see, the most frequently met criteria is behavioral integration of behavioral health providers into primary care practices. And in fact, you can see that all of the ones who completed the survey are meeting this criteria. And this we think is actually pretty surprising because kind of going into this, we thought of this as one of our more advanced standards. So it's interesting to see. And then on the other end of the spectrum, we see that only 14% of practices are tracking and referring, or tracking and following up on their behavioral health referrals. And again, I actually think this is fairly surprising. This is one of our criteria that we had adapted from NCQA's PCMH standards. So I think, going in, I would have thought practices had some experience doing this, but we continue to see that it is definitely one of our most challenging criteria. So going forward, as I said, we're definitely taking kind of these results into account as we implement our TA program. And as we engage more with practices, we hope to add a bit more color, as you were saying, around the strategies for implementing these different criteria and challenges and barriers. So for our 6 criteria that have to do with behavioral health screenings, we request, but we don't, it's not mandatory that practices submit their screening rates over a 3-month period. So for practices that opted to give us this information, what I have on this slide is average screening rates as well as the range of screening rates that were reported. So in terms of averages, I think one pattern we're seeing is some of our more newly introduced criteria have lower average screening rates than some of the more long-standing criteria. The big exception to that is the postpartum depression screening, which is the highest of the screening rates, and we find that surprising, and we're not entirely sure why that is, but it's something we're definitely going to talk to practice about and look into more as we go forward. We did note that the sample size for that one was much smaller than the rest, so perhaps we just kind of got more of a skewed, a small sample, or skewed sample, but
I'm not mistaken, so pediatric practices are taking this on, so that may be part of the reason.
Mhm.
And I think, if I'm not mistaken, MS Health is paying pediatric practices to do that, so, so that could explain, I don't know what percent of pediatric practices,
Yeah,
but
I'm
that
not
would
sure.
explain a lot of it, I think. I have to say, I'm really disheartened by the substance abuse screening, and I wonder, why is that and how can we fix that? Because here we have this opioid epidemic, and this is a huge funnel of resources and concern in our state, and yet we're only 29%. So how do we fix that? I don't know if this kind of, I don't know who's pediatric and who's not, but it just seems to me that we should focus on that particular measure and try to figure out why is it low and how can we increase it. It's not that hard to screen.
Yeah.
I think people don't screen because they don't know what to do with the dentist.
Yes, agreed. And something else that I think I found interesting and quite surprising is really just not just the hours, but the range of screening rates here. So most of the practices in this sample are certified practices. So we see that some certified practices have a less than 10% screening rate for a lot of these, while others have over a 90% screening rate. So I think this really just shows the variation in behavioral health capabilities even among certified practices. And as you said, still, if they're certified, plenty of opportunity for improvement, perhaps through TA. Okay, so we're nearly through this, but before we get to some discussion, we wanted to just round out the picture here by reminding the committee about some of the activities that we've had underway related to training and technical assistance. So as you know, we've been running a series of trainings with PCMH Prime practices through NCQA to help them really understand our criteria and documentation requirements. To date, we've had 5 webinars and 2 in-person trainings. We have another in-person training coming up in May and a webinar in June. We've had good attendance at these, and our survey results have shown that they've been received well, and the practices have found them helpful. So we'll be continuing those as we go forward into 2017. And about our technical assistance, which we've now mentioned a couple of times, you may recall that we began our first 6-month cohort of technical assistance in March. And we have 20 practices participating in this first cohort, a mix of those that are on the pathway to PCMH Prime, 15 of those, and 5 participating practices that have achieved PCMH Prime certification, but are involved in the TA to continue building on and expanding their behavioral health integration capabilities. One of the key modes of our TA delivery, the practice coaching aspect, has begun, launched in March. We have our first learning collaborative session next week, and we will have our second session also later in the month of May. And in addition, right now we have 7 webinars under development. These focus on more specific topics that relate to behavioral health integration and the PCMH Prime criteria, such as screening, brief intervention, integrated care management, and medication-assisted treatment, among others. So, by and large, I would say it's been a year of a lot of important milestones for the program overall, and really a year largely devoted to getting this program off the ground. And now, as I said at the outset, as we move into the second year of the program, we want to be thoughtful about our goals and to make sure that we focus our work on activities that will drive the most value overall. So, for your consideration and our discussion together, these are our proposed key areas of focus for 2017. Obviously, we do want to continue recruiting additional practices to participate in the program. We think it's important to engage and really to continue to support as many practices as we can in their behavioral health integration efforts. So we will continue to focus on this area going forward. Another obvious key focus will be continuing to fully implement our technical assistance program. And I think this is well in keeping with HPC's overall goals of convening and partnering with organizations
to achieve our mutual goals. We particularly want to ensure that our TA program provides opportunities for practices to learn from one another. This peer-to-peer learning opportunity that we know practices really value. At least that's what they've told us to date, and that we can see having a lot of value. And Dr. Allen, I think this is akin to what you were just speaking to a moment ago. So this will continue to be an area of focus through learning collaboratives and the technical assistance program broadly. A third thing that we would really like to do is that we want to build on and extend the analysis that we've presented today by doing some additional analysis and reporting in collaboration with our colleagues on the research and cost trends team, and using some data from the all-payer claims database. We'd like to be able to compare changes in cost utilization and quality outcomes of patients that are attributed to PCMH Prime certified practices compared to patients that are in primary care practices more generally. Our goal with this, is not to try to establish a causal relationship necessarily between the PCMH Prime certification program and these kinds of outcomes. But we do think it would be helpful to at least be able to further describe the overall performance of practices that have engaged with us in PCMH Prime, and perhaps even more importantly, have undertaken this significant behavioral health integration work in some shape or form. So we're really looking forward to diving into that and hope to have more to say about that coming up. And finally, we do want to continue to engage payers. We think this is an important aspect of supporting practices. We would like to raise the profile of PCMH Prime among the payer community and what it signifies. And we'd love to see more payers be willing to take steps about communicating to patients the practices in their networks that are PCMH Prime certified, and potentially in some of their product design decisions as well around tiering or other aspects of product design. So those are, I think, our proposed areas of focus, largely in line with the work that we know we need to continue to do from a project management standpoint of fully implementing this program. But also, I think, highlighting what we've learned over this past year and wanting to make sure that where we're putting our attention will really be the kinds of activities that are best going to support practices as we continue to go forward. So we'd love to hear your feedback, your thoughts, questions on the data, or other ideas you have, especially if there are notions you have about other areas of focus for the coming year that you'd like to see us add to this list.
I think it's really important to learn from people who are in the program as much as possible, especially because it is a relatively few number of practices compared to the total number of practices in the, that are either NCQA or PCMH Prime. So let's learn from them what's good about it and what we can be doing better, or what the needs, maybe almost a needs assessment of what is it that they really need to transform their practices, and are we providing that, or are we missing about something?
I think these are great areas of focus. I would just think about at what point do we go back and look at the standards to say either they're they need to be improved in order to get the kinds of outcomes we're looking for, or there are new standards we want to add. Obviously, we want to do that in partnership with their own work, but just something to think about and I think that will come from each of these efforts, but I'll just put that on the list.
Yes, thank you, and that's definitely on our minds as well. I think we're thinking about that as NCQA rolls out their 2017 program and is adopting many of our standards into their PCMH recognition program. That's a fantastic development, and I think shows the impact that this program is having, that NCQA is building our standards in at the national level. And to your point, it also will spur us to think about how do we continue to innovate and to make sure that our program is on the leading edge of continuing to push and support practices to make these kinds of changes.
So I like everything that's here. I guess I have a split thought, which is I suspect for the practices, the single biggest benefit of being in a program like this would be the opportunity to have better clinical quality, to feel like they're caring for their patients better. And so I think doing some analysis like in number 3 related to the quality of care that's delivered and are the patients really benefiting from that in as rigorous a way as we can do it and hoping to feed that back would be quite valuable. And then also letting them know areas where other practices may be doing well or if they're doing well relative to other practices or something like that. So I suspect for a lot of the practices, the clinical end is the really important end. I think for our purposes as well, we also care about the cost end of things. And I think to the extent that we can really show that there are savings that come in choose your favorite place, ED utilization, or hospital outpatient departments, or whatever else it is, I think that we can then push the payer community to reward these programs more financially, where it seems like some of them are starting to do so, but others seem to be a little bit less inclined to do that. I don't think the costs are the be-all and end-all here, because if all you do is you make patients better off and you don't save any money, I don't want to call that a failure. Maybe right. But I think thinking about those two aspects would be helpful in terms of the practices and in terms of expansion.
Totally great, thank you.
Any other? Thanks very much for that presentation. That's good. I think we're going to get more percent demo. How this is playing out.
Yeah, I will introduce, I'm going to shift over there, Dr. Fitzgerald. Here. So speaking of hearing more from practices and learning from actual practice experience, it's a great segue into the next agenda item. Joining us today are Dr. Deborah Blasey-Martin and Amanda Weintraub from Tufts Medical Center. And what we really want to do with this presentation from them today is to hear exactly what the committee has been discussing, from the practice level, what they're experiencing in PCMH prime. But we've invited them here today to tell us a little bit more broadly about their work, their journey to becoming medical home, their successes and challenges in behavioral health integration so far, and in particular, what more the HPC could be doing to support them and practices like them in achieving their behavioral health integration goals. So I'm delighted to introduce Dr. Deborah Blasey-Martin. She is Chief of Internal Medicine and Adult Primary Care at Tufts Medical Center. She's a member of the NEQA Board of Trustees and is also on the boards of one of NEQA's ACOs as well as the new WellForce ACO that I understand is seeking to participate with Mass Health in their new ACO program. In addition to leading primary care at Tufts, she sees patients, precepts, internal medicine residents, and is a founding member of the Women in Medicine and Science Committee within the Tufts Medical Center Physicians Organization. Prior to her current role at Tufts, Dr. Blasey-Martin spent 3 years as the medical director of Women of Means, now known as Healthcare Without Walls, which is a physician-run nonprofit organization that brings volunteer physicians to Boston area women's shelters to provide medical care. Increasing primary care access and services has been one of Dr. Blasey Martin's key priorities since becoming chief at Tufts. And to further this effort, she's worked to add a number of affiliated community practices, as well as to grow the academic medical center practice to its current capacity, serving more than 38,000 patients. This practice is recognized by NCQA as a 2014 Level 3 PCMH, and as you know, recently achieved PCMH Prime certification. And the site has also been nationally recognized for work on managing patients with chronic opioid use disorder. And Amanda Weintraub is a licensed clinical social worker. She practices within the Tufts Internal Medicine and Adult Primary Care departments. And in that role, she's responsible for providing individual short-term therapy to patients. She also performs crisis intervention and clinical assessment and provides resource support. Prior to joining Tufts in 2013, Amanda spent a year in the Boston Public Schools as providing individual psychotherapy to students. And her career in mental health began at the Wayside Youth and Family Support Network, where she spent several years in a variety of roles, including as a community outreach worker and a coordinator of programs for young adults. So with that, I will turn it over to them and really look forward to hearing more from their perspective.
Thanks so much, Karen. I really appreciate it. And thank you to the commission for inviting us. I think this is a wonderful opportunity for us to share our experiences. And it sounds like that's actually what you're really interested in, not just creating a program, but making sure that it works. So on behalf of our providers and our patients, I appreciate that very much. I also wanted to mention that Liz Barnhart, our nurse practitioner and clinical director of nursing, was supposed to be here today, but the Joint Commission showed up yesterday. So we're a little bit short-staffed on this group, but the work that Liz has done for this, for our patients in our medical home has been instrumental, and our nurse practitioner group is a strong part of all of the work that we do. So first of all, I just wanted to let you know a little bit more about us, so you have a sense of what our practice is and what it looks like. We are physically located on the Tufts Medical Center campus, so we are within view of the State House. We are also, we can wheel our patients directly to the emergency room and to the inpatient hospital. So we are, like many, a large academic medical center practice. We have about 40 physicians. Some of them do urgent care, some of them do primary care, some precept residents, some don't. They go all the way from seeing one session of patients a week to 8 sessions of patients a week. So we have a very diverse group of physicians in our practice taking care of patients. We also have, we're split up into 5 suites on 3 floors in the View building, which is right next to the Wine Center if you want to visit. And each floor has a nurse practitioner. We also have in our practice 3 social workers. Amanda is the lead social worker of our group, but we have 1 per floor. We also have 2 physician's assistants who, in part, help us population manage our chronic opioid patients. So that's a different program that I can talk about. And then all 72 internal medicine residents at Tufts Medical Center rotate through our practice for their primary care. As mentioned, we are a member of NECA, so that's our extended physician network. And we take care of about 38,000 patients. And when I think about what that really is, I think about sitting in Fenway Park and looking around me. That's the size of the practice there. That's the patients that we serve. It's an awesome responsibility, and it's very, very big. When I think about who they are, we're an inner city practice, so we have patients from everywhere. We are the local community hospital for Chinatown, so we do have a significant commitment to our Asian patients. One of our 5 suites is dedicated in part to taking care of those patients. So at check-in, John Tat speaks Mandarin, Cantonese, and Vietnamese and checks the patients in. Our medical assistants speak Mandarin and Cantonese. That floor, the nurse practitioner also speaks Mandarin and Cantonese, and 3 of our physicians speak Cantonese, 2 speak Mandarin, and then at checkout they also have sort of door-to-door service with people who speak their language and understand their culture. So one of our 5 suites is able to care sort of more deeply for the patient population that it really is our community, although I think our community is Boston. So we have patients coming from Dorchester, Roxbury, South Boston, now the Seaport, and really, Chinatown's changing. We have a large number of patients coming from these enormous high-rises that are growing up all around us as well, so we're seeing some demographic shifts in our patient population. Thinking about our insurance base, which is important for figuring out how we take care of our patients, about 45% of our patients are Medicare and dual eligibles. About 20% are Mass Health primary, and then about 40% are all varieties of different private insurers. So we really are serving patients in all kinds of different payment models. And we, like all academic medical centers, like to think of our patients as sicker and more complicated than everyone else's. But Tufts is a really tertiary and quaternary institution, and we do care for a lot of patients who are cared for by our subspecialists. We make more heart transplants than anybody else in New England, and so we see some of these patients. So when I'm doing urgent care for a patient who has UTI, I often look at their problem list and find out they also had a kidney transplant. So it's complicated. Our patients are many and varied, and so providing care to them requires many different approaches. And we're a practice that likes to innovate. We see our role in an academic medical center as making the changes and being on the forefront of what's going on in practice delivery. And so in 2010, we participated in the state's patient-centered medical home initiative. So we've been on this journey for a long time. We participated, we had technical assistance, we participated in learning collaboratives, and we got a lot out of it. I think we are strongly committed to being a patient-centered medical home. We initially certified by NCQA in 2013 as a level 3. And we did that on the strength in part of really trying to pilot team-based care, doing one-to-one MA models, and working on our staffing. And we found that over time it was very hard to roll out that level of staffing to our entire practice. And so when we recertified in 2016, we had innovated in other areas trying to find ways of doing population management with fewer people. So we do a lot more with our EMR, more with our portal. We've been working on doing more phone blasts, we're exploring texting, we're looking for other ways to approach all these people, but the bottom line really is that population management is costly. It's important, it provides excellent care, but it's not necessarily always easy to administer. With respect to behavioral health, we actually got started on this journey I don't know if anybody's familiar with the Partners in Integrated Care program that happened through ARC and MHQP back in 2012, 2013, but we participated in that as well. And at that time, we started doing PHQ-2s to screen for depression for all of our patients. And we found that that was something that we were really, really pleased with the way we were able to integrate it into our practice. It worked well, going from the PHQ-2 positive to a PHQ-9, screening for depression and making sure that we had adequate resources to take care of these patients made sense to us. We did, and this is a point that was raised earlier, we did actually at that time also screen for substance abuse and alcohol abuse with the DAST and audit tests, and we weren't really able to implement those. And in part it was because at the end of the day, once you identify these people, you have to know what to do with them. And that was more challenging for us. We didn't really have the resources embedded in our practice to population manage the patients. And to be honest, we didn't think we were identifying very well with the screening tools. I don't know that you were really, you kind of can't hand them 2 questions and have them say, yeah, I drink too much. So it wasn't perfect, and so it was something that we really didn't decide to dedicate the resources to. But that does lead me to the challenges that we've been facing as we try to put more behavioral health into primary care. I think the biggest is always the resources, and when we think about how we manage multiple subgroups with population management, we need to have people that we can dedicate to doing outreach in between visits. And we're lucky to be part of NEQA. NEQA has given us some wonderful resources. We have a nurse care manager who helps us take care of our chronic, sick, complicated patients. She can do home visits, but because she's funded by NEQA, she is funded in the risk products that NEQA owns. So I can't sit with a patient and say, oh, I have the perfect resource for you. I have to look at her insurance and make sure that indeed the perfect resource is also available to her. We also participate.
Which insurance categories?
The biggest chunk of the money in NEQA comes from our Blue Cross HPC contract, but we also, NEQA has been really good about the fact that we're now in a Medicare Shared Savings Program, ACO, and saying, okay, since the ACO infrastructure is coming from NEQA, anybody who's in Medicare you can also give these resources to, which has been a huge change for us. It's made a big difference because now a much bigger percent of our patients are actually able to get this resource. But again, it's one person, so it's for our thousands of Medicare patients, she can only serve so many. But thinking also about the ACO models, NEQA did very well in the 2015 Medicare Shared Services Program ACO. We saved $7 million, but that was in 2015, and the money actually came to us in fall of 2016. And so when I sit down with hospital leadership and say, I want more people in my practice to be able to serve these populations, and I think we're going to make money later. It's hard for me to come up with an argument that resonates with them that says, yep, you can pay these salaries right now on the promise of making money later or saving money later, which is even more challenging. So when I look at sort of where our money comes from, about 60 to 70% of the patients in our practice are in some kind of risk model. But about 85% of our revenue still comes from fee for service. And so making the arguments I need to make to hospital leadership is challenging. The other thing that's challenging about behavioral health is unique to psychiatry. Access is a huge challenge. And as much as I believe primary care should be doing behavioral health, there are things we can't do. We send patients to an oncologist when they have cancer and we want someone to prescribe chemotherapy. We have patients with incredibly complicated psychiatric illness and diagnoses that we can't do by ourselves in primary care. And so when we think about, how do we get people in, we have a lovely psychiatry department in Tufts. They're very good, but they have limited access. We try to send people out, and Amanda can speak a little bit more to the challenges there. As a physician, I can send them to Amanda, but Amanda still has to figure out where else she can send them. A number of our physicians sit down and say, here's the website for psychologytoday.com. You should be able to find somebody there. That's not really okay. Obviously substance abuse disorders are another big problem that we face in people that we serve, and there historically have been real challenges in the resources, although, again, Amanda can speak to this as well. It's getting better. We're actually finding more beds, and a lot of this really is due to the incredible attention the state has put on this problem. So I think that we really are seeing progress, but there's still some distance to go. The other big challenge of psychiatry is communication. There are policies in place, rules and regulations that make it harder for them to share all the information that they get with their patients. So we don't always hear back from psychiatrists. Amanda may give patients a list of psychiatrists that she thinks are appropriate to them, and we never really know if the loop is closed. I think if there's something that you can take home from this, access is really important, but communication is also critical. So finding ways to make it easier for the psychiatrists who are out there at whatever place they are to circle back to the primary care doctors and have those collaborative conversations to be able to allow us to take care of these patients. We're trying to take care of all of their medical problems, and having, knowing exactly what medications they change, what they think is going on, is really important and harder than it should be.
Have you ever tried to form a network of psychiatrists who would be open to your patients?
I mean, as an academic medical center, we have our own psychiatry practice, and so they sort of serve informally as our network. We have one psychiatrist there who's been fantastic with bringing in our patients and sort of providing an informal collaborative care network, but we haven't really.
And then the community side, you haven't been able to make that work.
Not to that. I don't know if you can speak to that a little bit more. We have done some community outreach to different places for substance use and had some success, but for psychiatry, I don't think as much.
No, and I think that for us it made sense for our base to be our psychiatry department and the psychiatrists within the institution. And I think that we've done as best we can with that, but they are not able, a lot of them have full panels and they're not able to take on our patients long term, and that's really the greatest struggle.
So there's the PAC program for pediatrics, which is sort of a network that at least can make some referrals and referrals. And actually, when I was working at Harvard Vanguard and we had our own psychiatrists, we didn't always have child psychiatrists, or there were a lot of reasons why patients might not, including insurance reasons, why they would not stay within the system. So I found that some of our pediatric practices actually also use MedPAC. So you might want to think broader about the bigger universe to try to connect.
Sure, and I think that's a really good point. But for a lot of the folks with mass health, when we think about making new connections and relationships, psychiatrists outside of the institution typically price insurance.
There is a state-supported program for pediatrics, whether they could consider expanding to adults. People are thinking about, and they're thinking about postpartum patients. So one more step
They have, actually, there is a McFat for moms.
for moms, right? But now how about adults in general? Yeah.
So, I think, sort of to the larger picture, we really believe that a big part of behavioral health does belong in primary care. We build these relationships with patients, and when I make a warm handoff from my patient to Amanda in person in that place, the trust that they have in me goes directly to Amanda. They follow through. They're more likely to get the care that they need. So I think, if I want to be able to take excellent care of their diabetes and their heart failure and their COPD, knowing that their depression and anxiety are managed better,
allows them to participate and engage in their care. So it makes sense, and it's the right thing to do. It doesn't mean that it's without challenges. And I think, just sort of to summarize my thoughts about it, we want to keep innovating. We want to be continuing to figure out how to do this work and to do it right. And if I were to sort of tell you what it is that's sort of my dream approach to this, is I would like us to be able to have a sustainable, payer-blind, team-based approach to behavioral health and primary care that we could actually maintain and continue. I think it decreases physician burnout. I can tell you just in the time that we've had 3 social workers in our practice, when I sit and I have somebody decompensating in my office, if they're in tears and they have incredible psychosocial stressors and challenges, but I also know I have a 20-minute office visit and somebody else waiting, being in that corner is a terrible place. And being able to pick up the phone, call Amanda and say, hey, come help me with this patient, and have her come, sit down, say, you go see your other patient, I'm going to chat with this person right now. I feel like I'm providing wonderful care to these patients, and it matters. And so, anything that you folks can do to help us to get to a place where it is payer blind and sustainable, and then I can go to hospital leadership and say, this is what I need, this is why I need it. It's going to provide excellent care for our patients, and it's the right thing to do. I much appreciate it. I have to say, I'm really excited to work with Myra Sessions, who is our consultant from Health Management Associates, and we are actually really thrilled that when we were able to be certified on the strength of our initial application. And so I don't have to look at the end of this process as a box checking exercise. I can say, okay, Myra, sit down with me. How are we going to come up with an ROI that I can bring to my leadership to integrate more behavioral health and primary care, so that they can say, oh, this actually does make sense for us. And also I can say, how can I put together some registries for some of these other conditions that we just haven't had the bandwidth to manage. And so I'm grateful for the assistance. I appreciate it.
Glad you're in the program.
Thank you.
Any other comments or questions from commissioners? Thank you so much for coming and sharing your experience. It really, I think that is where we need to be looking at the practice level and learning from you and helping you like push on things.
Can I ask one quick question? What are your thoughts about how you want to engage psychiatry in this process? And we as primary care doctors see all of the initiatives coming at us. What do we do to get our and social. But what are your thoughts about how you will integrate, how you will include psychiatry in this process?
Questions?
Well, this is reminding me of a couple of conversations I've had recently. On the TA side, we have been working with HMA to think about the opportunity to bring together some psychiatrists and primary care practices in a knowledge sharing session. So one of the modes that we're trying to offer with this TA program is some dialogue like that, not only for the PCMH prime practices, but for any primary care practices that are interested. But one of the ideas that HMA had was, look, we need to get primary care and psychiatry talking to one another more. It's an idea that we're still developing, and maybe we can talk with you more about it to make sure that we're planning it in a meaningful way. It would undoubtedly be only a first step, but the purpose of which at least would be to maybe begin a dialogue, maybe try to think about partnerships that, or at the very least, make sure that primary care practices are aware of what psychiatry resources there are, and then have a chance to talk about challenges, for example, in sharing data, just as you were discussing.
Yeah, I mean, I think payment is an issue. Are they in the same plan? And communication of information is also an issue, as you mentioned, about these privacy concerns, but we really do need the feedback. So how do we help navigate that? So why don't, maybe we at a policy level can sort of make some recommendations.
I've thought about this only a tiny bit. And start that when we think about like post-acute care, there's more or less a meeting point that's made for placing patients. Where I think, if I understand it right, if you have a patient in the hospital who needs post-acute care, you post it somewhere in all the nursing facilities and rehab facilities and so on. see that you've got a patient and then they say, yes, we can take the patient further. And there's a bunch of, and there's sort of a market that works where they understand that they're going to get repeat patients and interactions and so on. And so it's not, if I understand it right, it's not that TAPS Medical Center or the patient has to call every single nursing home in a 5-county region and figure out which nursing home would be able to take the patient. Or worse yet, discharge them and say, go home and call these 73 nursing facilities and see which ones can take you, and best of luck to you. And so there's that, but we've never worked out anything similar on the behavioral health side. So there's no sort of, as best I understand it, although you can correct me, there's no market that says, hey look, I've got 2 or 3 patients today, and I know I'm going to have 2 or 3 every day, but they're going to be slightly different, and so let's find a way to place them with some set of providers who are willing to accept some, on an ongoing basis, some set of patients.
No, so no, there's not, and I think I would take it a step further when I think about substance abuse treatment and how many folks have to call and look for detox beds on their own if a social worker isn't available to help them with that process. So across the board, there is not a process implemented for folks who have these persistent major mental health conditions.
I don't know if we want to expand, I'm going to move to my right because that's the relevant direction for this. I don't know if we want to experiment and see whether something like that could be set up.
Well, I was going to suggest too that the mass health restructuring into ACOs and value-based payments has as part of it behavioral health community partners and long-term support services community partners. And so as mass health for the Medicaid population drives folks into accountable care, which includes following through, which includes sharing information to the extent that you can and be compliant, HIPAA compliant. That is part of the goal and certainly one of the main purposes that the Secretary is considering. In terms of the sort of bed finder, if you will, through the emergency department boarding task force work group, we have been actually trying to understand how that works, system by system, hospital by hospital, and make some recommendations about how that should proceed going forward. And it should be the hospital social workers that are aiding in that transition, and who's in the hospital's networks and insurers' networks, and so those two things are happening at the same time, and will be coming out with some recommendations.
I would just say, David, your model works if there's excess capacity. We know there's not capacity.
It's although I agree that's true, although I don't know like if every hour that licensed mental health practitioner has is full, or whether there's some hours that are not, that
Right. Some of
on a short-term basis,
some of the
say,
practice models may need to change.
It's Wednesday morning and I've got a patient and they need help. Does anyone have an hour this afternoon or?
And we do that, we cover each other, so if I'm in session, then the other social worker is covering me, and that way he's
Right.
available to
But there's all, but
practice.
one could imagine the entire system sort of being set up in a way that could make that transaction be a lot easier.
I do know in the hospital setting, a lot of what happens to get people to post-acute care is related to care managers at the hospital who know all the different places and help. They've already sort of narrowed down the list of what's appropriate, what's close to your home, what has the services that you need, and then they talk to. And then we also see care managers from all these subacute facilities or post-acute facilities wandering around our halls. So there's sort of an economy of scale that it's probably not possible to do behavioral health. It would probably have to be more electronic and less on the ground people. That makes a lot of sense.
Well, thank you again. Oh, we have to come back.
You're welcome.
Thanks for coming. That's so good.
Thank you.
Thank you. Oh, I'm sorry, yes, the next, while you're changing chairs, now that we have a forum for Kim, just to present this.
So with a quorum, a motion to approve the minutes from January 25th, 2017.
So moved. Move approval.
Any, all those is there a second?
Second.
All those in favor? Minutes are approved. Thanks.
Thanks. Okay, so now please take over and walk us through the assistance design for our ACO certification.
Great, so thank you very much. Good morning, everyone. We are joined today by Bailiff Health Purchasing, Michael and Aaron, who will be leading a majority of this presentation. I'll just do a little bit of framing up. They are our consultants in the design for our ACO Technical Assistance Program. So we started adopting this new framework that we have for new projects and programs here at the HPC. And so I wanted to start by highlighting for the committee which policy levers and action steps this particular project aligns with. So it aligns really well with our second and third policy levers, promoting an integrated system and advancing aligned and effective incentives across the delivery system. It also aligns really well with our convening and our partnering strategies. Obviously, technical assistance is a direct partnering strategy, but it also plays on our convening role in bringing providers together, just like we just did, to talk about best practices. And so last framing piece is our care delivery fishbone, which I know Carol is a big fan of. So
I absolutely love this time, Grant.
So I'm now supposed to use it in every committee presentation that I do. But I think it is a really helpful framework for thinking about technical assistance for accountable care organizations. You know, these sort of are the 6 foundational elements of care delivery transformation, along with governance and partnerships, which is obviously really stressed through our ACO certification program, to lead to accountable patient-centered care. So when we think about technical assistance, we think about it along these 6 kind of broad categories of the actual care delivery model, the kinds of analytic work that a practice and system can do, the HIT systems, what kind of behavioral health support do they have, like we just heard about, how can they address those determinants of health, how do they engage patients and families in the practice operations and the practice design, and then lastly, do they have the right financial incentives, which we also just heard a lot about as well. And so we think about TA on any and all of these. So as a refresher, you all know this really well, but our ACO certification program standards also provide a nice framework for thinking about, should TA be aligned with the standards themselves or should it be broader? And so here, these are the 6 assessment-based standards that we all know and love. They fall into the governance structure, 3 requirements, the requirement to have a quality-based risk contract, population health management programs, at least one focused on behavioral health and focused on social determinants of health. And then partnerships. So how is the ACO working with behavioral health providers, specialists, hospitals, and long-term services and supports providers? Obviously, we have some supplemental information ones, but for this purpose, we'll focus on the assessment ones. We also do have our first application for ACO certification that is in process right now, so it's a huge milestone that we just completed. So ACO TA isn't just about the HPC ACO certification program. As you all know, the CHART program was designed and continues to drive community-based hospitals toward value-based models. And so making the community hospital ready to enter into alternative payment models, and so be good partners to ACOs. And so, you know, here is the overview slide of phase 1 and phase 2, but phase 3, this becomes even more important in the last phase of the program. And so, you know, as you'll see when we discuss this at the board, we are envisioning 2 pathways of funding in CHART phase 3. The first is continuing some clinical programs and funding clinical staff, and the second is more of an ACO readiness pathway. Is, you know, do the community hospitals need to purchase a care management platform that can make them link better to their ACO, other sort of enabling technologies, do they need legal help to create agreements with community partners? And so there is a part of phase 3 that we are contemplating ACO readiness for community hospitals. And so TA could also, you know, this kind of ACO TA would be helpful to hospitals participating in that pathway. So
The last big frame is obviously the Mass Health District program. It's a very large amount of money, between 20 and 40 million, that Mass Health has secured from the federal government to be able to give out to both ACOs as well as community partners. And they have broadly put out 7 buckets for which ACOs and community partners can apply for technical assistance. I won't read them aloud to you, but they're listed here. They're pretty far-reaching. And I know Michael and Erin will touch on this, but a big concern for us is timing and alignment with this, right? So this is a huge pool of money. Our pool of money, as you'll see on the next one, is slightly less, and so we want to make sure that we are being synergistic, to use a consulting term, with what they're doing, and making sure that our program really is focused on that all-payer lens of enabling ACOs to do what they do for all payers and not necessarily just the Mass Health population. So that being said, some goals from the staff's perspective, obviously, is to accelerate care delivery transformation. We very much want to promote alignment for TA between our certification programs and our investment programs, and more broadly with the Mass Health ACO program that's being rolled out at the end of this year. And think about focusing TA within our ACO certification standards. The ACO certification standards are pretty broadly, so even within that, I think we have some room for discussion about where to focus technical assistance. We have about $2 million over 3 years, starting in FY18. So with that, I will turn it over to Michael and Erin. I will guide for you, so just let me know.
Okay, thanks, Kate. Good morning, everyone. Erin and I are pleased to be here to share with you the information we've gathered. As Katie indicated, we were asked to help assess the technical assistance needs of ACOs. And in order to do that, we conducted a small set of interviews. We spoke with 4 Massachusetts ACOs. We focused on organizations that serve large mass health populations. So Boston Medical Center's ACO, ACO, the new Community Care Collaborative ACO, which is a network of community health centers, Lowell General from Circle Health, and Signature Health. In addition, we spoke to 2 health plans. We spoke with Blue Cross Blue Shield and with the Mass Health part of Tufts. We use a script and asked the ACOs about what their needs were, and we asked the payers what the ACOs' needs were, and heard some different things as one might expect. We also tried to assess to what extent were TA resources available to Massachusetts ACOs and other sources. So we looked at federal and state level programs, and we found that there's not a lot, to be honest. I mean, what Kate described as being in the offing through Mass Health would be significant, but today there's not that much. And then finally we met with Mass Health. So we categorize our findings into 2 categories. One, systemic findings. These are challenges to ACOs that really can't be addressed directly through TA to ACOs, but represent opportunities for system level change that the Health Policy Commission might be able to address. And then we looked at specific opportunities that were more amenable to TA to individual ACOs. I'm going to review some of the systemic findings, and then Erin's going to walk through each of the ACO-specific TA opportunities. We did find, as I just noted, that there are limited resources available to ACOs today, and linking what you do and not having it overlap or confuse or get muddled with what is going to be done with district dollars is important. So let me share a little bit on systemic barriers. As I said, these really aren't ideally situated to be addressed by TA, but it's important to note them because they came up in the interviews both with the ACOs and with the payers. The first one, and we heard this multiple times, is despite all of the payment reform activity, healthcare continues to be paid on a fee-for-service basis in Massachusetts. And that's a significant source of frustration for both payers and ACOs alike. the ACOs in general were quite frank with us in our discussions, and they talked about the difficulty of engaging physicians and engaging hospitals when the more you do, the more you get paid is still ruling their world. So there may be an ACO budget that exists, but the individual hospitals and clinicians, when they look at where their bread is buttered, it's in volume still. Massachusetts has been ahead of most states in terms of doing population-based payment, but there has not been so much activity in what I describe as the payment under the payment, which is how hospitals and physicians get paid and how physicians who are employed get compensated. Because even a lot of those compensation models are still RFP-based. So this is a much broader issue, and perhaps the Commonwealth can play a role here in promoting both new compensation models and new payment models that fit underneath ACO population-based budgets. But this probably isn't a primary TA opportunity, although maybe there is on physician compensation.
I was just going to ask, Katie, we've spoken about this at the commission on a few occasions, and I can't remember where we left off those discussions.
So I think the payment under the payment is a huge policy issue. And I think part of the challenge is that we still very much are, and Dr. Blaise Barton just said, her own practice is still, 3/4 or more fee for service. I think sort of the ACO model and the global budget model needs to sort of have a little bit more traction before there can be a terrible amount of attention to how ACOs are then distributing that money. That being said, we will be collecting a lot of information from ACOs about their shared savings, shared deficit distribution methodologies through ACO certification. It's all confidential. This is a high sensitivity area for ACOs because it is sort of their business model. It is their business model. But we will be getting that information, and then with that information, I hope to come back to the commission with those findings, and then think about what are some potential other policy recommendations we could make around it. From my knowledge and talking to a lot of ACOs, it's terribly different. Like each ACO, some of them can give them to a pod, and then the pod can just use that money to hire medical assistants to key in quality measures. Others can actually pass that money down to augment the RVRVS sort of incentive system that the individual clinicians are already on. So it's pretty diverse, but I think we have to let the global budget model play out a little bit more and get some more information and then be able to hone in on a clear recommendation. But I'm interested in thoughts.
I'm not sure I totally agree with that in the sense that we had spoken about episode payments, like bundled episode payments as maybe a complementary strategy to the overall ACO payments, not as a substitute for them. So it may be that we should revisit.
And I know the American College of Surgeons has developed a whole system for approaching bundles or episodes. So there are national or outside organizations that want to do this as well.
There are examples from other states of activity here. I mean, not a lot, but there are examples. It's not our focus today in terms of sharing with you TA opportunities, but if you would want to explore in the future, I'm very confident. Our second finding is that delivery systems still struggle a lot getting real-time data. And that's both getting very basic admission, discharge, transfer feeds, but getting other information about what drugs been prescribed, what are the lab results from other providers. That's a problem, as is sort of a higher level need of ideally having a shared care plan. These are just tools that are not available, and they certainly impede efforts on the part of the ACOs, including some fairly nascent ACOs, to develop the necessary infrastructure to manage care.
I think it is worth saying, I'm not sure how familiar the committee members are about the Mass Highways work to roll out the statewide event notification system, and so they're in the process of doing a procurement to get a vendor to do the statewide. So I think, at least on the ADT feeds, the admissions, discharges, and transfer feeds point, I think there is some state work that could potentially ameliorate this issue, but the shared care plans and sort of everything else under it is still a huge barrier as Michael said, particularly for like the non-hospital based ACOs that then have to figure out when their patients are in the hospital.
And then finally, we had a couple of ACOs share with us the challenge that they have in determining where their opportunities for improvement exist. They get multiple reports from different health plans that all give them a sliver of their patient population benchmarked against the plan. And one ACO said, well, so this health plan tells us that we're the most expensive, and this one tells us we're the least expensive. So it would be nice if there was all Massachusetts benchmark that ACOs could use to assess their performance, cost utilization, quality, patient experience. That doesn't exist today. So, these are things you might want to consider for the future in terms of developing infrastructure. This is sort of public utility support for ACOs, things that it's hard for them to develop totally on their own. Let me transition now and ask that Erin review the 8 areas of need that were identified for us. As I noted earlier, the health plans told us things that were a little bit different than what the ACOs told us. This is going to be a synthesis of what we heard from the 2, and I think at least on a couple occasions, Erin might make a distinction to let you know that we heard this from one party but not from
Thank you, and thank you all. So the 8 areas of key needs are listed here, and I'll take each of them individually in a little bit more detail. The first one, data utility and analytics, really fundamental to the operations and eventual success of an ACO is to be a data-driven organization and really use data to drive clinical and financial improvements. And this represents everything from data collection to data analytics to really the experience using the data and passing it on to physicians and really empowering them with the information. So ACOs really need a sophisticated data, capabilities, operations to both inform and manage their population health strategies. The second one, what we heard from interviewees were many topics related to the care delivery redesign. Interviewees identified behavioral health integration, care management, community partners, and community health workers. And multiple ACOs said that really strategically aligning and integrating the community partners and thinking about how to recruit and manage community health workers was an area of need that they're going to be focused on right away, given some of the requirements for Mass Health. But we also know that this is an area where there could be some alignment or overlap with the Mass Health district opportunities.
Yeah, and I want to add that the Mass Health request for application, which was certainly colored the comments that we heard. So when people were calling out community health workers and working with community partners, it was because they knew that the RFP was telling them that they were going to have to do this.
The third one, and this was really driven by one payer, but we also heard it in part from across the board, was really support for ACOs in managing a total cost of care and the cost growth and cost. But if ACOs and providers aren't at risk or don't have a lot of risk or there's limited risk, they might not necessarily see the value in this type of investment or support.
And some of the organizations with whom we spoke don't have much of any experience taking risk for the Medicaid population. And if they are safety net providers, even if they have risk for their commercial business, it's been traditionally risk for their commercial HMO business, which is not a large percentage of their overall patient population.
I think the downside risk part is really important too, because most ACOs in the state, the only downside risk thing that they are bearing is the Blue Cross AQC. The Mass Health ACO program is downside risk, right? But most ACOs are in SSP track 1, which is upside only. The other large commercial payers are largely upside only contracts. And so the ability to actually manage a downside risk contract is something we've heard that folks need help with.
And what we've seen actually in just about every state we've worked is that until organizations have some meaningful downside risk, they do not fundamentally change their
What do you mean when you say they need help figuring out how to manage?
They just don't know where to go to generate savings. And if they've been operating either with no ACO contract or it's just shared savings, the shared savings incentive is not a particularly powerful behavior change.
The fourth one, physician engagement and compensation. We heard that there are opportunities to really engage physicians about the role and the function of an ACO. This seems to be well understood at the leadership level, but it hasn't necessarily trickled down to the participating physicians. And we heard this multiple times from multiple organizations. And it's really critical to get the buy-in from the physicians and also see if you can form physician champions that will help to drive some of the delivery system changes.
We're really blunt here. I mean, we were speaking to physician leadership and they were saying we can't get our own people to be engaged in this. And sometimes they would reference fee-for-service payments being part of the problem. But it was surprising to hear them say, help us find a way to engage our own colleagues.
And another area of this is where there are employed physicians. ACOs may benefit from, understanding non-RVU-based models of payment. We heard from one that said, describe this as an extreme RVU world, and any transition from that would need to be very slow and methodical. And we also know that there are some non-financial incentives that will drive physician behavior change. And for example, those could be performance assessments where you've got peer comparisons or peer feedback. The next one is strategy and business planning for hospitals. So we know for hospitals, their goal is to fill the beds, and for ACOs, it's to improve quality and reduce costs. And one way they're doing that is reducing ED inpatient and hospital utilization. So there's this inherent tension and conflict. So particularly for hospital-based ACOs, some strategic guidance on aligning their business and financial goals with the goals of payment reform and where we're headed would be really valuable.
I think this is where, blinking light, chart phase 3 TA may come into play.
The next one, social determinants of health. We heard from many ACOs that there's significant opportunity here, that it is very important. They identified several topics within this sort of area, such as coding, developing and implementing screening tools, measuring quality, really understanding the parameters around flexible spending. And this is all critical, but we also really view this as kind of stage 2 in ACO operations, that they really need to get fundamental core competencies down, and then this would be sort of your first priority in stage 2. Next is understanding and managing risk. We talked a little bit about this before, but this could include support for financial modeling and methodologies for allocating savings. We heard that there are some struggles with distributing savings, across PCPs and specialists. And finally, in terms of governance, one payer said, very strongly that ACOs needed support in their governance structure. And they said that the only reason that, these ACOs formed is because of the district funding opportunity. And there may not be really an alignment in the governance, the body, around a singular vision or strategy. But of note, we didn't hear that as an area from any of our ACOs. So next I'll talk about our recommendations. We understand that with limited resources and limited funding, there needs to, we need to really prioritize the investment. And we recommend that both in targeting, the ACOs that would receive TA support and also what the areas would be. And we recommend that the Health Policy Commission target those ACOs that are participating in the certification program, and by default, that would include the Mass Health ACOs. We think they should prioritize newly formed or comparatively less experienced ACOs and ACOs that are comparatively less resourced. And the areas for which we would recommend the Health Policy Commission target would be on the core, central competencies that an ACO needs to develop to implement and then sustain operations. And those are around strategies for and methods for analyzing and applying data and care management of high-risk patients. And I'll go through each of them right now. So as I talked about earlier, the importance of data and how fundamental it is to the ACO operations. TA support, we imagine, could be in assisting ACOs in developing a data strategy or a data plan versus, funding that for an ACO to go, procure a vendor to help with data collection. What we found and recommend is that ACOs really need to understand what data is most valuable, how they can manage it, how they analyze it, how they can convert it into really actionable and meaningful information for providers, and then how they relay that information to providers. The second one, care management, identifying high risk, and this includes identifying high risk patients, understanding who and how care management is provided, and then making sure that the delivery of that is high quality and cost effective.
These are very, very basic competencies for an ACO, but in our conversations, we found that these were not competencies that all ACOs had in place. One of the ACOs told us, we don't know that we've hired the right people to do care management, we don't know that they're focused on the right patients, and we don't know that they're performing care management the right way.
I have a question about, so identifying high-risk patients. If you think that social determinants might be big risk factors, but you're postponing that part, how do you, how do those things jive? Because if you say, okay, our high-risk patients are just the ones with diabetes or the ones with severe mental illness, but not the ones who can't get to the doctor because they're home or are homeless or something, then are you missing the boat on a whole bunch of patients?
Social determinants, I think you would address a couple ways. One is considering social determination and stratifying your patient population, and the other is actually helping to ameliorate the social determinants of health. I think we were suggesting that the latter be put off.
Right, and not the stratification.
Right, the stratification, but I also want to be honest about it. So the knowledge of how to do this is quite limited. There's no standard collection of social determinant data in medical records. People don't even agree on what information they should collect. And there's no science that applies social determinants to predictively model which ones are going to have the most impact. Mass Health is breaking a little ground on this, but this is a very new field, and there's some limitation in terms of how the information can systemically be applied to identify high-risk patients. And when I mean high-risk patients, it's patients who are likely to be using probably inpatient services in the next 6 months.
So you've probably seen there have been a couple of papers recently, Michael Williams at Harvard Medical School, basically saying that care management hasn't saved much money, and that the way you save money is just by doing fewer things, in particular like reduced use of post-acute care services. So I understand the virtue of B, but is that obvious that that's the best way to help them with their ACO contracts as opposed to here's your rate of discharge to skilled nursing facilities instead of home health, and how you could get more in line with where everyone else is, or there's opportunities to standardize care that you're not taking advantage
So,
of.
yeah, I think our assessment is that standardizing care and developing preferred clinical pathways is a real heavy lift. It takes a long time. It requires a lot of clinical infrastructure. We spoke to one ACO and they said, we don't have an episode group. So they essentially can't compare how the physicians in their ACO are delivering care for a common condition or procedure. And if you don't have that analytic tool, it's pretty hard to standardize care and find any efficiencies. So our assessment is that if the right care management resources are applied to the right patients, that's not easy to do, but if it is done, that's likely to generate a near-term return that will be easier for them than the standardization of care, which they need to do.
Can I also jump in? I think I certainly had not thought about technical assistance as a way to help the ACOs be successful under the contracts. I have thought of ACO TA in light of what we just discussed around PCMHTA. Like, how do we partner with these systems and help them build the competencies that we're asking them to achieve in the certification programs? Set of governance, set of analytic systems, set of population health management programs, of which this care management piece here is foundational. But it's an interesting question back to you all. Do you think the goal of TA should be helping them be successful on downside risk contracts or risk contracts more generally? Or should the goal of this program be more of a partnership with the delivery systems and helping them build sort of foundational capabilities? It's an important question.
I mean, I think for how do you define success? I guess is the question. Is it, I mean, if you say helping them to make their patient population better off, or then yes, that is a reasonable goal. But if you're saying, I want this system's going to be successful, however you define that, like financially or whatever, this one maybe not so much. That I think is a waste of our resources. So, playing one against another, that's not our motivation. So I guess it depends on how you define success. I had one question about, I agree about selecting relatively under-resourced systems, but is there a danger there that the ones that are very well-resourced will go down their own pathway, and they'll go down a different pathway, and we'll have these disparate, ways of running an ACO or getting, in other words, can we capitalize on people who have the resources to help us say this is a really great way to do it? You know what I'm saying?
I had an interesting conversation with someone from the Robert Johnson Foundation recently about how they decide to fund. And they said, look, we're not interested in helping organizations that are struggling. We want to support organizations that are innovating and are taking us to the next level. So that's a decision that you need to make. I think our approach was that the policy interest was that all of the ACOs are successful, particularly those that are going to be serving a vulnerable population. And so that was the bias or the lens that we used. But you could take the RWJ approach and say, no, we want to support innovation and advancing best practice.
I think you also noticed we did not suggest that Michael and Aaron interview partners. So some of the more well-resourced ACOs, we suggested that they interview folks that could really and honestly tell us what they think they need help on. So I think there is an inherent bias in all of this, and if folks think that we should be providing technical assistance to the more well-resourced systems, then that's a good conversation to have.
Especially for the today. I think helping vulnerable patient populations is
I think, obviously, one thing you're highlighting is that we're in a period of change. And as we experience that change, having flexibility to support where it's needed will be important. And as you suggest, aligning with the Mass Health implementation of the ACOs will be particularly helpful. And I know HPC is doing that. So I think it's a hard question to answer right now. Although the base premise of supporting development of ACOs, certainly from the interest of the mental health is going to be important to the extent that folks need help getting off the ground. That's, help should be strategically deployed.
All right, well, I know we are a bit off time, so I'm gonna just quickly take us through the end of this and if folks have thoughts about this, we welcome conversations offline at any time. You've heard this as sort of our core priorities here, complement mass health program, complement internally to the HPC certification and investment programs, and focus the TA around our certification criteria as a framework. Again, the two recommendations that Michael and Erin have made align with these two buckets of our capabilities, fishbone, and I think that's great news. I don't think the money that we have is going to spread across all 6-7 domains here, so I think it's good to focus. Our timeline and next steps, we are where the start is. We have this team until the end of June. We'll come back to the next committee meeting with a final proposal for TA, and then we'll spend the summer implementing it. Do we need to procure some vendors in order to do this? Do we operate it as a grant program where then the ACOs are able to, once they go through the certification process, which will wrap up by the end of this year, are they able to ask for money through a grant program, or do we hire a couple vendors that are able to provide help in these particular areas to everyone? That's an open question that we have to work through with our team. And then hopefully launching the program at the beginning of next year, which is the launch of the district program. So I think we're very sensitive to asking provider systems to apply for a lot of different things in different ways. And Michael and Erin have highlighted that maybe we want to kind of be out ahead of the district time, so that way we can start some foundational work ahead of that money being available to them early next year.
And the ACOs did tell us we could use the help now. We're doing the work now to get ready. So providing TA earlier would respond to that.
So we will work as fast as we can for our team to work through this. But really welcome thoughts offline. And thank you to Michael and Erin. This is a great presentation. Thank you very much. Really interesting.
Thank you.
So as folks move around, we also have another program update, which is on the neonatal abstinence syndrome interventions that HPC has been behind now for just about a year. And so I'll turn it over to Captain River to start the conversation along with him.
Commissioner Cohen. So I'm going to hand it over to Hannah Plumack in a moment. I want to remind you what we're talking about and introduce her as well. So as I'm sure you all remember, we invested in 6 hospitals across the state to support them in doing quality improvement work with respect to the way they're treating neonatal abstinence syndrome, the diagnosis infants can experience after being exposed to opioids in utero. We are launching those initiatives now, and Hannah, who's our program associate and really managing this entire program, will give you an update about one of the hospitals that has already started a performance period, as well as where the others are. All of them are the finalist contracts, and they're making great headway, so we're excited to tell you more. I'll let Hannah give you a brief reminder of the very complicated funding stream that we set up here, so that we could align with DPH, which is a really important initiative, but it sometimes creates a headache in terms of thinking about how our dollars flow. So she'll give you a little reminder.
Thank you, Catherine. Okay, great. So this diagram, I think, we've determined is probably the best way to explain the different programs that we're investing in. You can see there's 3 different funding streams, and they all affect different parts of the continuum. So our pilot program, which is 4 of our initiatives, are implementing this pilot program. It's a quality improvement initiative. It's focused on inpatient care with a target population of infants who have been exposed to substances. And so our target population for this one is all infants who are going to be monitored for LAS symptoms. These awards were capped at $250,000,
And so we have 4 awardees, that would be Bay State Medical Center, UMass Memorial, Boston Medical Center, and Lawrence General Hospital. This stream is the DPH program, which they're implementing. They're about a year into the program now. The funding for this came through a SAMHSA grant, and they awarded this funding to 2 hospitals. So at Cape Cod and UMass Memorial, they are implementing a program with a target population of pregnant women with opioid use disorder. So this focuses on care for the mothers during pregnancy and then after they've been discharged with their babies from the hospital. For our other 2 grants that we awarded, we took the design of the DPH program and kind of replicated it in these additional 2 sites, as well as building out kind of what we wanted to do with our inpatient program. So these programs are the full continuum. We enroll pregnant women with opioid use disorder during their pregnancy. We are implementing our quality improvement program inpatient and treating the infants who are born exposed to substances, and then also providing those supports to the mothers following their discharge. So we're working closely with DPH to provide those outpatient services, and then we're working closely with the hospitals to provide that inpatient care. So the hospitals where we're implementing this initiative are Beverly and Lowell General Hospital. So you can see from here the different types of activities that our hospitals are going to be engaging in. The inpatient programs are really focusing on, as we said, quality improvement, so it's standardizing and implementing protocols for best treatment of infants with NAS. That includes introducing breastfeeding early on and increasing the breastfeeding rates, providing appropriate pharmacologic care to the infants who require it, and making sure that they are engaging in skin-to-skin contact with the mothers as frequently as possible. The overall goal of our program is to provide this best care with the hopes of reducing the inpatient length of stay for these newborns. Our outpatient programs are focused on providing support to pregnant women with opioid use disorder. So this is making sure that they're receiving behavioral health supports as well as their prenatal care in one location and not having to travel to numerous different sites to receive this care. Providing social supports such as child care and transportation, and really increasing their engagement in MNT. So here are our 6 hospital awardees. As you can see from this diagram, it shows how many of them are still in their preparation period, and how many have actually begun their implementation. So we're about split. 3 and 3 are still in preparation, and 3 have actually begun their implementation. So we're starting to get some of the first results back from our hospitals. All of them have done outreach to engage with their community providers in their area, which we think is a really great sign. Even the ones that necessarily, so as part of the design of the Moms Do Care replication programs, they are required to engage with their community providers, so that's part of the design of the program. The inpatient programs, we recommended it, and all of them have taken us up on that recommendation. So that's really great. 4 of our hospitals have completely staffed up their teams, and 3 of them have completed all of the necessary staff training and have actually done, deploying all of their team members to serve this population.
So what is the team look like?
They vary, but depending on the hospitals, we gave them a little bit of leeway in terms of what they thought we wanted them to propose, what they think is most useful. One of the challenges, which I'll get to in a second, is that finding qualified peer coaches, recovery coaches, which it turns out all 6 of our hospitals are engaging in that workforce. They also have social workers on staff. We have, in the inpatient, for the inpatient programs, it's mostly focused on engaging in NICU teams with the special care nursing teams and pediatrics teams, as well as labor and delivery to make sure that there are smooth transitions of care. So all of the members of those teams are engaging in training of recognizing the symptoms and also how best to treat the mothers as well as the infants. So as I mentioned, the peer recovery coaches have been a significant barrier to a couple of our programs. All of them are using this workforce in different ways, but it's been difficult to find the best ways to introduce necessarily this kind of position into different hospital systems, as well as then publicizing the open positions and receiving, garnering interest to get people to come in and apply for that position. So this is something that we're working really closely with ESAS to kind of overcome, but a couple of our hospitals have found that the only staff that they're really struggling to locate and hire has been this peer recovery workforce. So here's a spotlight on Bay State Medical Center, which is implementing our inpatient quality improvement program. Just as a overview of the Bay State program, one of their aims is to increase breastfeeding rates and skin-to-skin contact rates by 50%. So this is a look at their enrollment from beginning of January through March, and doesn't include any numbers from April yet. So they have seen 28 substance-exposed newborns were delivered at the hospital. 18 of these infants were cared full-term and 10 were preterm. The average length of stay for those patients was 20 days. 68% of them who were monitored for NAS did require pharmacotherapy, and the average duration of this treatment was 10.5 days. 61% of the infants had early initiation of skin-to-skin contact. 89% successfully started breastfeeding, and 53% were still breastfeeding at discharge. So to give a little bit of context to these numbers, we have some of the numbers from the full calendar year of 2015. So in 2015, Bay State Medical Center treated 112 infants with NAS. So, 28 is exactly 1/4 of that. So it seems like they have a pretty stable grasp of what that population looks like. In 2015, 86% of the infants that they monitored for NAS required pharmacotherapy. And the average inpatient length of stay in 2015 was 22 days.
So I'm discouraged that the breastfeeding went from 89% to 53% in 10 or to 20 days. Do you think that's because of the length of stay and the mothers kept with the baby, or do you think what's the way to improve that? Because it should stay at 89% or close to that. But
yeah, and that's our hope for over the course of the program, that we're going to be able to increase those numbers. I mean, it's not. We're hoping that they'll be able to make sure that 100% of eligible infants successfully start breastfeeding, and that they continue that practice throughout the discharge. I do think that a big part of it is the mothers are discharged after 2 or 3 days, and then the infants are there for 20. So a big part of the program is trying to get a higher parental presence at the bedside, and so we're hoping that will impact the breastfeeding rates and the skin-to-skin.
Some of them just let the mothers stay longer, or any hospitals able to do that? Is that an insurance issue?
We're hoping that we're going to be able to increase. We have a measure that they'll be tracking for rooming in, and so part of that is while they're in the hospital, but then also it's measuring how much time they spend even after the parents are no longer, or even after the mother is discharged from the hospital, how much time they spend with the baby in the hospital. And so I think we're hoping that as that increases and they provide more spaces where they can, with the mother and the infant can be together, those rates will go up.
Yeah, I think Dr. Allen, providing us a space for the woman to come back and stay near her infant is really important. Not all 6 of our hospitals are able to do that, but all of them are aware that that's sort of a longer-term policy goal. But we did see, and in making these awards, we saw that it was a big struggle in terms of not having even just the physical space to put beds for these women. So that is, you're right, that would be the best strategy. I think that most of these patients also face pretty significant transportation and childcare barriers. So the grants that are doing the pregnancy and postpartum supports are targeting and supporting them with that too. And a big role of the peers is to simply provide transportation and help them get back and forth to the hospital after they're discharged when their newborn is still inpatient. So Bay State is only doing the inpatient quality improvement initiative, so they don't have funds, at least from us, to support transportation and childcare addressing that. But as goes to the conversation we just had about ACOs and what they should be doing to address social determinants of health, which I know you're passionate about, Dr. Allen.
I'm just curious, sort of you made a comment about DPH, but how are we integrating these, our funded sites with DPH funded sites? And is there a community of practice among those hospitals?
Yeah, and that's something we're really excited about. So we are working with DPH directly in providing they're the ones who are kind of really, since they've been doing this work for about a year at their 2 sites, we are working with them to deliver those same services to our 2 sites. And we're very hopeful that we're going to be able to start. They've been working really closely with trying to get the teams kind of just ready to begin this work, and have given, there's regular standing phone calls where all 4 of these sites can kind of call in and talk about things, and they've brought a lot of the experiences that the other 2 sites have had into some of our meetings and discussions about things to consider. We're hopefully planning an event where all of the teams can get together, but it's been a little bit challenging just determining timing, but that is something that they planning on doing regularly. They have regular, I think, advisory council meetings for the Moms Do Care program, which our sites have now been integrated into. So there will be at least a few of these regular meetings, and they're also it's been made pretty clear that there's that they're welcome to contact them outside of those regular meetings with questions and for advice.
Yeah, and the services Hannah mentioned that DPH is providing are technical assistance for the most part, and then a pretty robust evaluation of the outcomes, and a little more robust than our evaluation because federal standards require more robust evaluations. We duplicated all of that. So an example of some of the translation of learnings that we've seen grantees ask for and DPH directly provide are things like the challenge for hiring peer support staff. DPH is facilitating the exchange of UMass and Cape Cod giving the 2 new hospitals basically staff descriptions that they posted, security checks that they ran, HR protocols that they're following to help these hospitals create new staff positions that they've never had before. And as Hannah mentioned, they do have these quarterly advisory council meetings that we sit on and the grantees attend. And they vary in terms of the agenda, but the grantees are often presenting to each other and having engaged in discussion with respect to how they're addressing these challenges that come across. So it's a great point, and thank you for reminding us that we really do want to be very integrated as we proceed.
Good question. Thank you.
Thank you.
Now move on to our last item, which is an update on the risk-bearing provider organization appeal process. We have Lois Johnson, Steve Pellet, our Director of the Office of Patient Protection.
Thank you, and in the interest of time, a very quick update today about the implementation of the provider appeals process. This slide reminds you of the process that OPP is required to implement for risk-bearing provider organizations and HPC certified ACOs. As you recall, it's a similar requirement to the parallel to our OPP appeals process for insurer appeals. And the process is intended to address concerns of RBPO patients for whom their providers are at risk regarding things like referral restrictions or other limitations on care or access. And again, as you recall, we have implemented this through an interim guidance to provider organizations that we issued last May, when we updated the timeline in July. But basically the guidance requires RBPOs to do 3 things in this interim period before we get to final regulations. First, establish an internal appeals process, according to the requirements of the statute, but with considerable flexibility about how exactly it's implemented given the variety of organizations that are out there. 2, to provide notice to patients about the process, and 3, to track and report on the appeals that they have received over a certain period. And so we received the first of those of the reports for the period from October to December of last year. Those came into us in January, and we just received the second reports for the second period, which was January to March of this year, which were due in mid-April. And so we wanted to we haven't analyzed fully the second batch because there's still some reports that have been delayed, but we wanted to give you an update on our activities to implement the guidance and a flavor of the kind of what we're hearing from the reports, and then it'll come back to me and I'll talk about our next steps.
Sure, so the Office of Space Protection, I think, sought to advance a collaborative process and employed several strategies for technical assistance, including 2 listening sessions with provider organizations. We developed a dynamic living, frequently asked questions document, distributed a template as depicted here on the slide to provider organizations, and then managed consumer calls and assisted them in understanding really this rather nascent process and the difference between what's distinctively different between this process and the carrier appeals process. As summarized in this slide, with the reports that were received reflecting the October through December period, the majority of provider organizations did not report any appeals or complaints, and of those appeals that were received, they largely pertain to referral restrictions, which I think is to be expected given the domain of risk-bearing provider organizations. And as Lois mentioned, we recently received the April reports, and those are still under review. As reported on the template, there were some elements which the provider organization had to describe what is the process established to handle these appeals, and one component of that was providing the notice that they made available to patients. As requested, most of these notices, I think, largely aligned with the template that the Office of Patient Protection provided. Some providers did go above and beyond, and I think sort of demonstrated some of the exemplar notions in providing patient-centered, culturally competent care by translating the notice into multiple languages. Other organizations really tried to hone their patient population's understanding of this process by denoting on the notice that this process only pertains to a particular carrier with which they entered a contract with. And then, as Lois also mentioned, I think the processes as described were as varied as the myriad governance structures that risk-bearing provider organizations have established. Largely, they basically had a triage function at the point of service for patients to really discern if the appeal warrants a review by their clinical team, and then only those patients who are attributed to the risk-bearing provider organization and do have an issue which may be, concern or restriction on the referral or treatment limitation or something of that sort, is then escalated to either a licensed clinician or a team of clinicians to review. And then Lois will talk about next steps.
Yeah, so we're seeing, provider organizations are complying and they are getting that notice out. And based on the reports that, even just the first report, there's clearly a lot, probably more notice that could be provided to patients to make them aware of this opportunity. But I think we need to understand more. And so our plan going forward is to continue the implementation of the interim guidance and require continued quarterly reporting. We've already given guidance to provider organizations to continue to track and keep records of the appeals. But beyond that, we want to do a proactive outreach and really try to go beyond the reports and really understand, now that this has been in place for several months, understand, what their process is and are they really capturing all of the things they should be capturing? Are they capturing too much? We did get a report from one provider organization that reported on complaints that really don't fit in this, so we're seeing some underreporting probably and over-reporting. And we knew going in that the difficulty here is the nuance of what are the types of issues that we should be capturing. We also want to understand more around the clinical reviewers and what their standards are so that we can build that out as we are required to do, which is building out an external review process. And to that end, we want to continue, so we do want to do in-person outreach and probably additional listening sessions with provider organizations, but we also want to look at contact and get information from external review agencies, both the groups that we contract with OPP, but also others around the country and their accrediting agency, which is URAC, to get more information about standard of review and competencies to have for an external review in this area. So our approach is sort of continued implementation of the interim guidance and continued understanding of how organizations are doing this before we move to developing the regulation. Our plan is still tracking towards starting the regulatory process at the end of 2017.
Question? Thank you. Your timing was
Excellent. I'm impressed that you've missed your 15.
anything else by any of the commissioners? I want to actually thank all the staff. These were great presentations as well as the guests. Very informative. Appreciate it. Motion to.
Motion to adjourn?
All those in favor? We're adjourned.